Hello everyone. Thank you for joining today's Web Interface Support webinar. This series of webinars is for accountable care organizations, ACOs, and groups that are reporting data for the quality performance category of the Quality Payment Program through the CMS web interface for the 2018 performance period. These webinars will highlight important information and updates about reporting quality data and provide ACOs and groups with an opportunity to ask CMS subject matter experts their questions. During today's webinar, we will also share links to various resources and other information that will appear as announcements on your screen. Please note that these calls will only focus on reporting data for the quality performance category. We will not cover reporting data for the other performance categories during these calls. Now I will turn it over to Lisa Marie Gomez from the Center for Clinical Standards and Quality at CMS. Please go ahead.
Welcome everyone, and thank you for joining us today as ACOs and MIPS groups prepare for CMS Web Interface Quality Reporting. Again, I'm Lisa Marie Gomez with CMS and a subject matter expert on the CMS Web Interface. Joining me today are other subject matter experts who will share helpful information on the CMS Web Interface Quality Reporting and answer your questions during the question and answer session after today's brief presentation. As previously noted, today's webinar is focused solely on quality reporting via the web interface. If you have any questions regarding MIPS, other performance categories such as promoting interoperability and improvement activities, or let's say quality reporting in general, please contact the Quality Payment Program Service Center. Next slide, please. This slide includes a disclaimer. So any information provided in this presentation is current at the time of publication. The information provided is only intended to be a general summary. We encourage ACOs and MIPS groups to utilize the source documents and other resource materials for a comprehensive scope of CMS Web Interface content. You can access the full list of materials via the links that are provided throughout the presentation. Also, for your convenience, we have provided the links in a pop-out box within the webinar. Please stay tuned for any communication or updates from the Quality Payment Program, your shared savings program, or your next generation ACO model. Next slide, please. The CMS Web Interface is now open for submission and will close promptly at 8 p.m. Eastern Daylight Time on Friday, March 22nd, 2019. Your submission will automatically be accepted at the close of submission. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. Next slide, please. Another important reminder, a CMS approved reason is a way to skip a patient attributed to a measure during denominator confirmation. Approved reasons are reserved for unique, unusual circumstances that are not covered by the denominator exclusions or exceptions. Please submit any 2018 CMS approved reason requests as soon as possible during the submission period. Requests sent after March 15, 2019 are unlikely to be processed prior to the submission closing. Please note that no other CMS approved reason may only be selected for a patient when the request has been approved by CMS. Next slide, please. So to request a 2018 CMS approved reason, please send an email to the Quality Payment Program at qpp@cms.hhs.gov. Please submit one request per patient per measure. In the subject line of your email, please use 2018 CMS approved reason request. Ensure you include the patient's rank, measure ID, and specific information about the patient's condition and why the condition would prevent the quality action from being performed. Do not include any personally identifiable information or protected health information under any circumstance. Next slide, please. Please mark your calendars. The next CMS Web Interface webinar will be held next week on Wednesday, January 30th, 2019, from 1 to 2 p.m. Eastern Standard Time. Topics will include frequent assignment and sampling questions, MH1 depression readmission at 12 months overview, frequent measure questions, Q&A session. Now I'm going to turn it over to Özlem Tassel.
Thank you, Lisa Marie. Good afternoon. I'm Özlem Tassel. Today I will be going over the changes to the data confirmation report and also provide an overview of the data irregularities report, which is a new report for this year. Next slide, please. No protected health information, PHI, or personally identifiable information, PII, is displayed in the following slides. All data shown on the screens is fake data created for testing purposes. There are no real beneficiaries or beneficiary IDs shown in any of the slides. Next slide. This year, you can access the data confirmation report both during and after the submission period. The data confirmation report allows you to review a real-time CMS receipt of your reporting data. You can access this report by clicking the View Reports link on the left navigation, and then by clicking the View Report button in the data confirmation box. Next slide. The data confirmation report displays your organization's name, tax identification number, the last time a change was made to your data, and the submission deadline. The reporting summary provides a snapshot of when the submission is due, the number of measures complete, and the number of completed beneficiaries. Next slide. In the data confirmation report, the measures are broken up into two sections: measures that have met the requirements and measures that have not met the requirements. Under each of these sections, there is a measure card for each measure that lists the measure name and description, an indicator whether the minimum requirements are met or not met, and the performance rate. Next slide. And here you see a measure that have not met the minimum requirements displayed. Similarly, this card displays the count of consecutively complete, skipped beneficiaries, numerator and denominator count, and the performance rate for the measure. Next slide. The data irregularities report is new for the 2018 CMS web interface. This report allows you to locate illogical reported data that may need additional attention before submission. There are two high-level categories of data irregularities in the CMS web interface: measure level and beneficiary level. At the measure level, data irregularities include measures with zero denominators. At the beneficiary level, data irregularities include if there is any measure data reported for a beneficiary who is not qualified for that measure, or if there is any inconsistent measure data reported, or if there is measure data reported for a beneficiary who is not qualified for the sample. Next slide, please. If you have data irregularities to review, the View Progress page will display a to-do item or card at the top of the page titled Data Irregularities and show you the number of items to review. Clicking on the View Items link will take you to the Data Irregularities report, where you can see all of the irregularly reported data that is currently stored in the CMS Web Interface database for your organization. Next slide. You can also access the Data Irregularities report by clicking on the View Reports link on the left navigation and then clicking on View Report in the Data Irregularities box. Next slide. Here you see that there is one data irregularity reported at the measure level, which means that the measure has a zero denominator. Each measure has specific denominator requirements, so you're encouraged to check to make sure this information is correct. In this example, you have a total of 32 beneficiaries, and all 32 beneficiaries are skipped. The medical record was not found for 12 of those beneficiaries. 5 beneficiaries aren't qualified for the sample, and 15 beneficiaries are marked as denominator exclusions. Next slide, please. And here you will notice that there are 13 irregularities reported at the beneficiary level. In the first beneficiary, measure data was reported for Ted Clerks, but he's not qualified for the sample, so this measure data will be stored but not used in performance calculations. In the second beneficiary, measure data was reported for Catherine, but she's not qualified for that measure, so this data will be stored but not used in performance calculations. Lastly, in the third beneficiary, inconsistent measure data was reported for Carolina Royals, so the measure questions answered may contradict the measure logic. This inconsistent measure data will be stored but not used in the performance calculations. Next slide. Now I'm going to pass it off to Sarah for the next section.
Thanks, Aslam. So in the next slide, I'm just going to review a couple questions that we see frequently regarding our assignment and sampling methodology. If you would go to the next slide, please, with the questions. So this first one we see quite a lot, where an ACO or a group says that we are finding a small number of patients in the beneficiary sample who haven't been seen by the organization in the past number of years, or in this case, let's say for 3 years. And they ask if this is the case, if they haven't seen the patient, should they be entering medical record not found, or is there another field to enter? So just a reminder that by the assignment algorithm, we have verified that the beneficiary was assigned because they were deemed to have had received a plurality of their services at your organization, as determined by claims that were submitted by your organization. In addition, the first step of our sampling methodology begins with looking for beneficiaries that have had at least 2 evaluation and management visits within your organization during the performance year. So therefore, your organization is considered accountable for the patient's care, and you should do your best to obtain the needed quality information to complete reporting. The next question is specific to the Medicare beneficiary identifier, the new identifier that we've moved to and away from the HICN. And we are getting questions about which identifier is supplied in the web interface. So what we've done is provide only one identifier, either the HICN or the MBI, and also a field that indicates which identifier it is. So actually it's a flag that indicates if it's the MBI. And we use the most recent claim that we can access and use whatever identifier is on that claim, whether it's the HICN or the MBI. And now I am going to pass it over to Angie to review the PREV-10 measure. Thank you.
Hi, this is Angie Stevenson, and I wanted to give an overview of the PREV-10 tobacco use screening and cessation intervention measure. The measure for 2018 has changed from the 2017 version, and it now requires 3 reporting rates to be reported. The population 1 are patients who are screened for tobacco use. So that is going to include all patients screened. Population 2 are tobacco users, and then those who have received tobacco cessation intervention. Population 3 are tobacco non-users and tobacco users who receive, and then if they are a user, who receive tobacco cessation intervention. By separating this measure into various reporting rates, the eligible professional or clinician will be able to better ascertain where gaps in performance exist and identify opportunities for improvement. The overall rate for population 3 can be utilized to compare performance to the prior published versions of the measure, as in the 2017 measure, but the rate from population 2 is the one that will be used to score the 2018 version of the measure. And I wanted to add that this information can be found in the Quality Payment Program Resource Library, in the 2018 Quality Benchmarks zip file, and it's included in the document named 2018 MIPS Measures with Multiple Performance Rates. You can find that there, and that's also included as a link in this presentation in the resources section. Next slide, please. Some guidance for the measure. To report the measure, you'll need to determine if the patient was screened for tobacco use at least once within 24 months. And the 24 months is defined as the 24-month look back from the measurement period end date. So that would be January 1st, 2017 through December 31st, 2018. If no tobacco screening is found in that period, the intent of the measure is not met. If there is more than one patient screening for the tobacco use, then you would use the most recent screening during that 24-month period to report the measure. You would also determine if the patient is a tobacco non-user or user for those that were screened. And if the patient is identified as a tobacco user, you need to determine if they received cessation intervention. Next slide, please. Here are some definitions from the measure specifications. The definition for tobacco use includes any type of tobacco. So that is smoking tobacco and smokeless tobacco. Electronic nicotine delivery systems are not currently classified as tobacco, as they do not burn tobacco leaves. So the measure does not currently capture e-cigarette usage as either tobacco use or a cessation aid. I also wanted to add a frequent question we get is, does smoking marijuana count as a tobacco user? And no, it does not, as it is not tobacco leaves, again, that are being burned and not tobacco use. The definition for tobacco cessation intervention includes brief counseling of 3 minutes or less and or pharmacotherapy. And if a patient uses any type of tobacco, they should receive cessation intervention. Minimal and intensive advice or counseling interventions conducted both in person and over the phone are included. Screening and cessation intervention do not have to occur at the same encounter, but they must be within the 24-month look-back period, and the cessation intervention must occur during or after the visit with the most recent tobacco user status. This was an intentional change so that tobacco users are provided cessation intervention as frequently as possible. Cessation intervention must occur after every positive screen to meet the intent of the measure. Written self-help materials, brochures, and pamphlets, etc., are not included as tobacco cessation and don't qualify for the numerator. Next slide, please. This slide shows the requirements for the 3 populations that need to be reported that we've kind of been over. Your sample is going to include all patients 18 and older seen for at least 2 visits or at least 1 preventative visit during the measurement period. So that's determined by the sampling process, and then you will report on the patients in your sample. The denominator criteria is shown for population 1, 2, and 3. Population 1 and 3 is going to be your initial patient population. Population 2 is just going to be patients screened and identified as tobacco users. Numerator, then, for population 1 are patients who are screened. 2 are going to be those tobacco users receiving cessation, and 3 are going to be patients screened who received tobacco cessation if they were identified as a tobacco user or if they were identified as a non-tobacco user. Next slide, please. So this slide was created to help illustrate what is required for the numerator and denominator for each population. Just for the purposes of this webinar. It's not to be used for abstraction or in place of the measure specifications or the measure flow. So the chart is showing all components with an X in the population column are the ones that are required for the patient to be included in the population, except the numerator column for population 3 where the asterisk indicates OR. So if you want to look through it, for all populations, you need to verify the patient is qualified for the measure first during the patient confirmation step. And then if so, that has to be verified for every patient to be in any denominator. Then for population 1, all qualified patients in the denominator are in the denominator, and then those screened are included in the numerator. So you can see the 2 X's in the numerator column. For population 2, qualified patients screened and identified as tobacco users are in the denominator, and those in the denominator screened and identified as tobacco users who received cessation intervention are included in the numerator. For population 3, all qualified patients are in the denominator, and then those identified as tobacco users who receive cessation and those identified as non-tobacco users are included in the numerator. So I hope that helps illustrate that measure a little bit better for you. I'll turn it over now to Jessica Schumacher.
Great. Thank you, Angie.
You're welcome.
I apologize if my slides are stuck. Okay, I see slide 26. Thank you. So now I'm going to walk through a couple of frequent measures questions, and I'm going to go through quickly just so we allow some time for question and answers today. So if I do speak too quickly, just throw a note up there and I'll slow down. So next slide, please. I might be having problems with my internet. So on slide 28, or 27 then, the first question that we have been seeing a lot of is kind of a general question that applies to many measures, and people are asking if they're able to use the diagnosis from claims to confirm the diagnosis or identify denominator exclusions to report a measure as long as the claim is present in the EMR. And a high-level response, and just kind of a good rule of thumb for folks to remember, is that claims codes are primarily used by CMS when they're attributing patients to the sample. So that's why you're going to see these people popping up in your beneficiary sample. When abstracting medical record documentation showing that the patient does indeed have the appropriate diagnosis for that measure is going to be required in order to confirm the diagnosis for the denominator or for denominator exclusions when you're reporting specific measures. And we strongly recommend that you do review all the denominator guidance that's provided in the measure spec, just to make sure that you're fully understanding all the different nuances for specific measures. Next slide. I am sorry, guys. I'm still seeing. All right, so slide 28. We have a couple MH1 questions. The first one is, what time frame should be used to confirm the beneficiary has a diagnosis of major depression disorder or dysthymia? And for MH1, the diagnosis of major depression or dysthymia needs to be documented either as a newly diagnosed or an active diagnosis during the denominator identification period, which for MH1 is established as December 1st, 2016 through November 30th of 2017. And if you have any questions about that, please feel free to send them in today or reach out to the Quality Payment Program. The second question we're getting about MH1 is, what time frame then should be used for denominator exclusions? And that's patients with the diagnosis of bipolar disorder or personality disorder, and patients then who are also permanent nursing home residents. So denominator exclusions can occur anytime during the denominator identification period, throughout the measurement assessment period, and the measurement assessment period is going to be unique to each patient based on the index date. And in order to calculate that measurement assessment period, you find that index event, and from that date you count forward 12 months, and then you can add 30 days to get the full extent of that period. So then for that patient, you would have from December 1st of 2016 through that last day of their measurement assessment period in order to claim an exclusion if they have anywhere in there an active diagnosis of bipolar disorder or personality disorder. Next slide. Then on slide 29, another MH1 question that we've seen is, please define permanent nursing home resident. And a permanent nursing home resident is defined as a beneficiary who resides in a long-term residential facility. It does not include beneficiaries receiving short-term rehab services following a hospital stay, nor does it include beneficiaries residing in assisted living or group home settings. If you have any questions about this, you're welcome to contact the Quality Payment Program. However, it's really going to be up to the group or ACO to kind of determine, based on your documentation, what type of facility that patient is living in. The next question for MH1, if a patient has a negative PHQ-2, then we don't do PHQ-9. Can we count the PHQ-2 as a negative depression screen to satisfy the measure, or does it have to be a PHQ-9? And the response is no. The measure developer has confirmed that a PHQ-2 screen, regardless of the result, cannot be used to submit remission for MH1. They have to be followed with that PHQ-9. Next slide. I apologize if I have a lag here. Okay, so the next set of questions are regarding PREV-5, breast cancer screening. And the first one is regarding the measure description for PREV-5 states women age 50 to 74 years, but the initial population denominator criteria states women age 51 to 74 years, which is correct. They're both correct. It's stated a little differently because the patient is not eligible for the denominator until age 51, but mammograms received beginning at age 50 are allowed for the numerator. And due to the grace period, the patient may have been 49. So just please be cognizant of those differential ages. The total look-back period for a mammogram includes the measurement year, the year prior to the measurement year, and a 3-month grace period for a total of 27 months to look back. The second frequent question we get for Prev 5 is document coding. The Prev document coding does not include CPT codes that replace the G codes for 2018. If the code is not included, is performance not met? No, the 2018 Prev coding document is considered all-inclusive, especially for purposes of EHR mapping. If there is a medical record documentation that the patient had a mammogram during the look-back period, then the intent of the measure is met. Next slide. And on slide 31, the third frequent question we're getting about Prev 5, a breast cancer thermography is listed as digital infrared imaging. Since digital is listed as one of the screenings that's acceptable, can we accept a thermogram? Sorry if I'm skipping over that. No, please refer to numerator coding in the Prev coding document for acceptable screenings. Breast thermography is not included and is not considered a primary breast cancer screening. And the last Prev 5 question is, how should we answer if the beneficiary refused the screening? So in this instance, you must select no, the quality action was not performed, as patient refusal is not an exception for this measure. Next slide. And the next slide is going to be our last slide of frequent measure questions regarding Prev 6 colon cancer screening. So for Prev 6, is it true that if a beneficiary refused a screening, that it's considered a no response? Correct. Patient refusal is not an exception for this measure, so you would select no. What if the beneficiary is not yet 50, for example, 45 years of age when they had the colonoscopy? Is this beneficiary numerator compliant if we have the date and results in the medical record? Yes, a beneficiary who meets denominator criteria for the 2018 measurement period and had a colonoscopy at age 45 during that 9-year look-back period would meet the numerator criteria for the measure. The date and results must be documented in the medical record. And question number 3, can you please confirm the Prev 6 measure can be met by patient reporting? And yes, Prev 6 can be met by patient reporting. However, there must be documentation of the screening date. We'll accept just the year, the type of the test, and the results findings. And the last frequent measure question for Prev 6 is FIT acceptable as a colon screening alternative or only FIT DNA? So yes, FIT is a fecal occult blood test, so it does meet the intent of Prev 6. Next slide. That should be it for the frequent measure questions. So I'm going to hand it over to Lisa Marie. Thank you.
Thanks, Jessica. So the next few slides will outline the available CMS Web Interface resources. As noted earlier in the presentation, the links that we've discussed have been provided to you in a pop-out box within the webinar. Next slide, please. So now we're on slide 34. So the items listed on this slide are currently available within the Quality Payment Program Resource Library. We'll continue to communicate any future postings in upcoming webinars. Next slide, please. So this slide contains a link to the CMS Web Interface instructional video playlist. Links to the individual videos may be found on the Resource Library page. Next slide, please. So the Help and Support page at qpp.cms.gov contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. We have also provided the links to resources within the Quality Payment Program webinar library. where you can find materials from the previous CMS Web Interface webinars. Next slide, please. So this slide contains links to resources available for the Medicare Shared Savings Program and Next Generation ACO model. We wanted to make sure that we provided you with all the links so that you'll have them in this webinar presentation, but also so that you know where to go to find these links if you do go to the Quality Payment Program website. Next slide, please. So this slide contains the contact information for requesting additional assistance if needed. Now I'm going to turn things back to Michaela for the Q&A session. Thank you.
Thank you. If we could go to the next slide, please. And we are now going to start the Q&A portion of the webinar. You can ask questions via chat or via phone. To ask a question via phone, please dial 1-866-452-7887, and if prompted, provide the conference ID number, which is 729-8764, and press star 1 to be added to the question queue. And please note, if you do have any follow-up questions or clarification that you'd like to share in the chat, please type follow-up question at the beginning of your chat question so that you can flag that for us. So to start, our first question is on PHQ-2. So in the past, the PHQ-2 questions were stated to be easily identifiable enough not to have it state PHQ-2 in the note. Is this still true?
Hi, this is Jessica Schumacher from the PIMS Measures team, and I can answer this from the measure standpoint, but I may call on the auditing team if they have anything else they want to add to my response. So for Prep 12, if your organization is using an EMR and you have the questions embedded in the EMR exactly how the questions are in the screening tool, and you have a written policy indicating that you're using PHQ-2, then that would be acceptable. If you have a question, if your setup is a little bit different, and I'm sorry I can't give you a yes or no response because every organization has a different setup. So if your organization has a different setup, then there might be different requirements. But Mary, did you have anything else to add to that response?
No.
Great. All right, we'll go to the next question. It's, will PT or OT referral count as BMI counseling for Prep 9, even when not specifically referred for weight loss?
Hi, this is Angie from the PIMS team. Yes, as long as the physical therapy or occupational therapy will address and benefit an abnormal BMI, it's acceptable. PT and OT are included in the definition of a follow-up plan on page 6 of the measure specifications. Thank you.
Thank you. Our next question is, what diagnosis codes qualify a patient for the MH measure?
Hi, this is Jessica, and I'm not going to be able to list all those codes right now, so I'm going to have to refer you to the MH1 coding document, and it's included within the zipped file with the measure specifications available on the QPP resource library. And within that document, it's a spreadsheet. There are going to be 2 different sheets that you can reference. The first one's the encounter codes, and that sheet lists codes that are used for assigning beneficiaries into the measures in your web interface. That list is only a resource tool. You can use it to locate the place in the medical record where that denominator eligible encounter occurred, but then you will need to look for the quality action preferred during any other encounter. So please know that that encounter codes sheet is only a resource for assigning patients. The denominator code sheet in the coding document will list codes that are used for confirming whether or not the patient is going to be denominator eligible for the measure. Thank you.
Thank you. Our next question is, does the length of counseling time need to be documented for Prev 10 tobacco use? And can you need to quit smoking count as counseling?
Hi, this is Angie. No, the length of the counseling time doesn't need to be documented, and counseling the patient to quit smoking would count as counseling. Cessation intervention does include counseling of 3 minutes or less, and you can find that in the definitions in the measure specifications. Thank you.
Thank you. And Stephanie, do we have any questions on the phone?
There are no audio questions at this time. If you would like to ask an audio question, please press star, then the number 1 on your telephone keypad. That's star 1.
Thank you, Stephanie. And so our next chat question says, my group reports via the web interface. Would a pathology report for colon polyps meet the intent of the measure for Prev 6?
So it would meet the intent of the measure if the date of the report fits within the time frame for the flexible sigmoidoscopy within that 2018 measurement period, then it would be appropriate. Thank you.
Thank you. The next question is, if a patient is seen in the ER or clinic as a result of a fall, does that satisfy the CARE 2 measure?
So in order to satisfy CARE 2, there has to be medical record documentation of a screening for falls history. Any fall with injury or a gait balance assessment will also meet the intent of the measure. If you have any other questions about a specific notation in your medical record, please submit to the Quality Payment Program. Thank you.
Thank you. This next question is, for CARE 1, if the discharge is from a behavior health facility, are we still required to have the medicine reconciliation doc in the primary provider EMR? And they say due to privacy and mental health, this is against the policy.
Hi, this is Jessica. So the CARE 1 document provides 7 different scenarios that would qualify as medication reconciliation. There are several that do not require. And by MedRec doc, I'm not sure if you mean, I'm assuming you mean like a discharge summary providing details about their psychiatric hospitalization. There are scenarios which do not require that to be in the outpatient chart. Please review the spec. I'm not going to be able to read through all 7 right now, but I believe items number 1, 2, 3, 5, and 6 may apply, and if you do not think they do, please contact Quality Payment Program and we'll take a look at it with you. Thank you.
Thank you. This next question is on Prev 10. If the original tobacco screen is done prior to 2017, the non-smoker doctor reviewed the social history at a visit during 2017 or 2018 and signed off, and it's still current. Does that count as fulfilling the measure?
Hi, this is Angie. As long as there's documentation in that 24-month period that the eligible clinician screened the patient for tobacco use or asked them if they were still a tobacco user and documented that, then it would count as screening and tobacco use status. Thank you.
Thank you. This next question is on medication reconciliation. If you have a hospital discharge date and a patient goes straight from the hospital to a skilled nursing facility and is there for over 30 days, how do we proceed? And they say they would not be able to do the medication reconciliation since they fall out of the parameter and that they've had a few patients like this.
Sure. So if the patient maintains an as an inpatient within 30 days after a discharge, then you would code no, and that patient would be removed from the calculation. Every discharge will require that you look to see if there's medication reconciliation within 30 days. So if you're not able to do that first discharge, then they may be sampled again later. So then you would try to find that skilled nursing facility discharge and do MedRec then. Thank you.
Thank you. And Stephanie, do we have any questions on the phone?
We have a question from Jane Simonson. Jane, go ahead with your question.
Can you hear me?
Yes.
Go ahead.
Okay, great. The question is, we have a few patients who did not have an office visit in the measurement period. How are those best to be handled?
So this is Sarah from ACO PAC, and I believe this is related to the question I reviewed during the webinar, but based on what we saw in claims, in fact, we located 2 evaluation and management visits within your organization for that beneficiary. So we would encourage you to use best efforts to locate those records and complete reporting on the beneficiary.
Very good. Thank you.
Sure.
All right. This next question is on the CARE 1 measure related to medication reconciliation again. And they say the patient is required to have an office visit within 30 days after discharge. And does a home visit with an eligible provider meet the intent of the measure?
Hi, this is Jessica from PIMS. So any type of outpatient encounter, office visit, telehealth, billable or non-billable, will count as long as the eligible clinician signs off on that medication reconciliation to just confirm awareness and receipt for coordination of care. If you have any reason to doubt that a home visit wouldn't fall within those guidelines, please contact the Quality Payment Program and we'll take a look at it with you. Thank you.
Thank you. For this next question, they say, in regards to IVD, if a patient received an anticoagulant medication only during an inpatient admission, for example, a single occurrence, but had not been prior to or post-discharge, are they still excluded from the measure despite actively taking aspirin on a daily basis?
Hi, this is Angie, and yes, they are still excluded if they received an anticoagulant at any time during the measurement period. We did confirm that with the measure steward. And I may have, I can't seem to find a question that I intended to answer, so I'm going to include it since it has to do with IVD. The question was, is heparin, would a patient that received a heparin flush in their IV be excluded from the measure? And for that purpose, no. Patients that just had a flush to clear an IV are not excluded. But if they actually received another form of anticoagulant, then they would be. Thank you.
Thank you. This next question says, the narrative specs for PREV 5 and PREV 6 identified denominator, the initial population, as patients within a specific age range and a visit during the measurement period. Does this visit have to be with a primary care provider, or do other visits, for example, a specialist visit, count?
Hi, this is Angie
Sarah.
again. Oh, go ahead.
Nope, Angie, go ahead. You take it. Thanks.
Okay, correct me if I'm wrong. No, any type of visit with an eligible clinician at the organization are included. You can look at the PREV coding document and counter codes, and those would be the codes that were used to attribute patients to your sample, but it's not limited to a PCP or, specialist visits can be included. Do you agree with that? I want to make sure I'm correct.
Yeah, I was going to say exactly the same thing. Thank you.
Thanks.
All right, thank you. And for Prep 9, is a BMI from an ED visit acceptable, or does it have to be done in the provider office?
No, it is not limited to an office setting. So it can be performed in the ED, and if the BMI would be abnormal, then there would also need to be a follow-up plan documented at that same ED visit. I also want to mention that there is a medical an exception that can be taken if the BMI is done in the emergency room or in an urgent care situation, and to delay the treatment, to finish out the BMI quality action would endanger that patient, then it can be that type of situation could be claimed as an exception. Thanks.
Thank you. And Stephanie, do we have any phone questions at this time?
We have a question from Marcella Chines.
Hi, this is Marcella. My question is with IVD. I just want to make sure that with the denominator exclusion, so if the patient was given heparin at any time, inpatient or outpatient, even if it was a one-time dose in a hospital, if they were admitted, that will exclude the patient from the denominator.
Yes, it would exclude them if they had even one dose during the measurement period.
Okay. We're having a lot of patients that had hospitalized that had it, either low enough of one time or something like that. Okay. Thank you.
Right. We confirmed that with the measure steward, and I can, if you want to write in, I can give you their exact words, but they did that basically so there would be no advantage or disadvantage to certain patients that may have had surgery toward the end of the year, I think was their logic, but I'd be glad to give that to you if you want to write into the quality payment program. Thank you.
Thanks.
You're welcome.
All right, this next question says, in the BMI section, it states if there's no BMI during the most recent visit, you may use a BMI during the previous 12 months from the most recent visit. Can you clarify if the BMI and follow-up plan have to be on the same visit date?
Yes, the abnormal BMI and the follow-up plan must be documented at the same visit. So you would start with the most recent visit and look for medical record documentation of a BMI. If there is not one at the most recent visit, then you can look back 12 months from the most recent visit for a recommended follow-up plan documented at another encounter that also had an abnormal BMI documented at that visit. But the two always have to be together in the same visit. Thank you.
Thank you. So this next question is in reference to some discussions on MH1 and major depression dysthymia from last week's call. So the person says, if I remember correctly, the answer to the question was that major depression dysthymia diagnosis and the PHQ-9 must have occurred during the same encounter. However, the specs indicate that the PHQ-9 may be administered via telephone, mail, email, patient portal, etc. And several of the administration types would not have occurred during an encounter that would allow for a diagnosis. Can you please clarify?
Hi, this is Jessica. Yes, I'd be happy to clarify. So for MH1, there must be an active diagnosis of major depression or dysthymia in the medical record. And that active diagnosis then needs to be associated with the same date that the eligible clinician documented the PHQ-9. So it's not that that diagnosis, it could be new, it could be ongoing. As long as the key here is that it has to be an active diagnosis of major depression or dysthymia. And I'm pulling up my spec. An active diagnosis, which again is the key, this is on page 9 of the spec, means that that diagnosis is either on the patient's problem list, a diagnosis code description listed on the encounter, or is documented in a progress note indicating that the patient is being treated or managed for the disease or condition during that denominator identification period. And real quick, while I'm off mute, I'm going to steal 1 minute just to talk a little bit more about MH1. If you're having trouble with this measure, please call into next week's webinar. We'd love to provide more information about MH1. I see a lot of questions coming in asking about the denominator exclusion timeline. And I just want to repeat what I said during the presentation. There appears to be some miscommunication as to what I mentioned. So I just want to reiterate that for 2018 MH1, we have guidance from the measure steward that there must be that active diagnosis. I'm turning to the of bipolar disorder or personality disorder during either the denominator identification period through the last day of the measure assessment period. And again, as I read off on a previous slide, that denominator identification period begins December 1st of 2016. So in the medical record, if you see an active diagnosis of bipolar or personality disorder, or if they're a permanent nursing home resident, at any time between December 1st of 2016, which is the beginning of the denominator ID period, through the last day of their measure assessment period, which is going to be 12 months from the index date plus 30 days, then if there's an active diagnosis or permanent nursing home resident anywhere in that time frame, then you can claim the exclusion. And we had one comment who noticed that it's not exactly a streamlined process, as why exclude a patient if you have to go through the process of identifying kind of some of the subsequent steps, and these specs are written for manual abstraction. We understand there might be processes in place to make them more efficient, but as the spec is written, you are allowed to, again, claim that denominator exclusion if anywhere between the first day of the denominator identification period, which is December 1st of 2016, through the last day of that patient's measure assessment period, then you can claim that exclusion. Thank you.
Thank you. This next question is, can we download the data irregularities report and divide it by measure?
Hi, this is Aslam. Data irregularities report is not available for download at this time. Please note that the report will change as you make updates in the web interface to the beneficiary data, either via data entry pages or via an Excel upload. And also one additional information, please note that the data irregularities are not errors. They are not required to be resolved. They are just either illogically reported data, or they might include additional data reported for a beneficiary. For example, if a beneficiary was not qualified for the measure, however, the measure questions were still answered for that beneficiary, this information will not be calculated in the performance calculation. So the data irregularities report identify the information that may be extra and was not required to be reported. Therefore, they are not errors. They do not have to be resolved, and you can still have successful submission having data irregularities. Thank you.
Great, thank you. And that is all the time we have for today. So if we weren't able to answer your question, please do feel free to email one of those email addresses that we sent out via the chat or the pop-up box earlier. And actually, if you'll go to the next slide, they are listed here as well. And we also encourage you to join us for our next webinar next Wednesday, January 30th. Thank you.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.